Our next speaker is Dr. Marjorie Kagawa Singer. I want to welcome her. She is a research professor, Professor Emerita in the Department of Community Health Sciences and the Department of Asian American Studies at UCLA. Well known to many for her work on culture and health. A major theme in her work is identifying different definitions of health and trying to understand whether the theories and models that we use to explain health and health behaviors fit well for multicultural populations. And so we look forward to her talk today to talk about how this relates to the concepts of health literacy. Please welcome Dr.
Thank you so much to Karen and the committee for inviting me for this presentation. The title of it is not what I was given initially, but what I've experienced both as a clinical oncology nurse and as a medical anthropologist in public health, talking about many of the things that Elmer introduced about what medicine could be doing that would be more effective. Is the miscommunications. We know what we're saying, but we're not sure what's being heard. And my husband, who's a physician, I say, well, the doctor never told the patient about X, Y, or Z of their condition, and that's why they didn't follow through. He said, of course they told them. Every doctor is going to tell them. And I go, yeah, right, but do they actually understand it? And that's what is the key, I think, of the ability to communicate the information that will enable patients to do what's in their best interest. And what often I hear from the patient side of it is when the doctor asks these questions, they're not clear on why they want to know it, and they want to know what you're talking about. My mother asked me once, is this the control? Thank you. Oh, I can't communicate very well. Read directions anyway. And she said, what is it you do? And so I tried to. My mother didn't have high school was her. She didn't graduate from high school. They were put in the camps as Japanese Americans. But so I tried to make it as clear as I thought, was possible. And she nodded her head all the time I was talking, and at the end of it, she said, that sounds so nice. I have no idea what you're talking about. And I think that's often when you add the anxiety of talking to a doctor, and it's your health, you're not going to hear half of it anyway. And then if it's in a language they don't understand or a vernacular they don't understand, nothing happens. And yes, then the doctor didn't tell them, what they needed to know. This is my area of research. And this was a paper written by Leonard Syme in 2008. Unfortunately, we're still in that predicament. In 40 years of research to eliminate health disparities, we have made no progress. So what are we doing with the gazillion millions of dollars that we're expending on patients in this country? And Elmer, I think, outlined it beautifully, is missing the population of color. And that in California, we were the first mainland state to have no ethnic majority. That will be the United States predicted in 2042, I think now. So we're fast approaching it. And if we can't get it right now, we're done for. I'm sure you'll hear this from all of us, all the many definitions, but it gives the patient the ability, or the individuals the ability, and for the capacity to obtain, process, and understand basic health information and services needed to make appropriate healthcare decisions. This is, to me, so fundamental to what all of us do in healthcare, and yet we miss the mark so much of the time. But it rests on the ability of the clinicians to have the communication skills that are necessary to speak to patients and families who do not have the education we all do in healthcare. the lay and professional knowledge of health topics, and what I'll be speaking on today is culture and how that impacts our ability to effectively communicate. The healthcare system is highly complex. You have to be very aggressive to get through it. I once was collaborating with a colleague who's a physician at UCLA, and we were working on a project. I was talking with him. I hung up the phone. I go, oh, I forgot to talk about one more thing. I call up the hospital, get the operator, and I said, please connect me with this doctor. And she goes, there's no one here by that name. I said, yes, there is. And finally, after being extremely forceful, which my mother would have been humiliated at with my behavior, said, get me your supervisor. And of course, then she connected me. But it's that kind of persistence that for many cultures, they would just not go there, right? Which means that's the end of the communication. And the demands of the situation and the context. I don't know how many of you are physicians here, but 15 minutes is not that long. For a first visit, they get, 25? How much of a history and a relationship can you build in 25 minutes? It's just not possible. So we have a structure that is antithetical to the whole purpose of building relationships. How can you navigate the healthcare system? One of my friends who is a physician took her parents who had moved from Texas to LA to sign up for Medi-Cal in California. And they sat at a county office for 6 hours. And finally, the office was closing, and she went up and she said, we're still waiting. I'm trying to get my parents signed up. And they said, oh, you're at the wrong office. And she says, I'm a physician. I couldn't even get that information right. So what are we doing to actually get the message across? I don't care about the words that you use, but are you getting the message across? Also, when you give them their cholesterol level, the blood sugar levels, measuring medications, do they know how to do that? Have you sat with that patient to figure out whether they understand what you're saying just tactily? In a project we did in trying to translate the medications, the names of the medications, the purpose, and the side effects to non-English speaking patients, this was an FDA project we had, we found that the patients they knew what the medications were for. That part they got. But they wanted to know what the side effects were. And how does the pharmacist translate side effects in 10 different languages? That's not available to them. You heard, it apparently was on television, but it was actually a clinical encounter in LA where this Latino gentleman came in, he was prescribed this medication, went home, he said, yes, he understood, when the doctor talked to him, how to take it, but it said, take it once a day. Any Spanish speakers here besides Elmer? Yeah. The patient read it once. Okay. So he overdosed on the medication. So it's those kinds of things, even if they think they're saying, you really need them to tell you back what it is they understood that you said, so that, and the way I usually say it, I want to make sure I've made it possible for you to understand what is needed here. And so they'll repeat back to me, and that way I'll get a sense of how clear the message was. How do you calculate premiums, copays, and deductibles? I have problems with that. People with less education are going to really be in a bind. These statistics just floored me. Only 12% of adults have proficient health literacy. 9/10 of adults may lack the skills to manage their disease, and 14% of adults have below basic health literacy. That's appalling. And that's also dangerous because you're going to see them in your emergency room. I was on call one night, I was on duty one night, and this woman calls in, and she says she wasn't feeling really well. She was dizzy. She'd been in the hospital for 5 months. She had just been discharged. She was home maybe 3 days. And I said, what's your pulse? And she said, I don't know. I said, well, can you take your pulse and tell me? She said, I don't know how. She'd been in the hospital for months. Nobody ever taught her how to do that and what it meant. So I was on the phone with her. I talked it through her. You know, she found her pulse, and she goes, 1, 2. She was in heart block. I said, have someone bring you in now. You know, it's that kind of basic information that as clinicians we think, oh, they've got to know it. You know, we do this every day. No, she didn't, and nobody bothered to check. How many of you have heard 5 a day? Eating fruits and vegetables? Yeah, we all have, right? This was up until 2009. Look at the 2013 update. It's gotten even worse. We've made not one iota of difference. This is also in health disparities. So where are we missing the boat? In essence, everywhere. You know, from the first encounters, the messaging isn't in a way that most people can understand it. This was a paper that was written in 2010. When I read it, I thought, where have you been my whole life? I could have been so much further in my career. Weird people do most of the research. That means white, educated, industrialized, rich, and democratic. And Henrik Heine and Noren Zion said they published it in Science and in Nature. So the science behind it is very solid. And they said, however, had they not been 3 white men, it would not have been published. 96% of researchers in health psychology and 90% of the subjects tested in theory are from weird countries. They represent only 12% of the world's population. Those of you who are researchers, every theory you use has been standardized on primarily white populations. That is not what makes up the United States. That definitely isn't what we do internationally, but our international colleagues are using our standardized tests and not checking out what it is with their populations and how valid it may or may not be. So keep that in mind, because that then underlies the rest of my presentation. We are a multicultural society, but a monocultural approach to healthcare that denies culture and context and complex determinants of health disparities. We need to view, usually it's, if it's cultural, as though that's wrong, you know, as to why they don't comply, why they don't understand, why they don't, whatever, that's interfering with their ability to follow through with recommended treatments. The sources of strength for patients and families is their culture. It gives them their reason for living and how to live. We have to employ techniques that would more productively be applied when transmitting information in cross-cultural encounter. Whoops, what happened to this one? The way we'll get there is to first recognize that there are fundamental differences in cultural constructs. The person, the individual, is defined differently. In many other, a colleague of mine from Japan, you know, the circles where you have individual, every psychologist knows that, the individual, the family, the community, you know, when you go on these expanding concentric circles. And when he wrote it up, he put family and patient in the middle, in the bullseye, and then went community, you know, and outward. And one of the classmates, and he's from Japan, one of the classmates who's not Japanese looked at it and she goes, Takami, isn't that a little claustrophobic? And he goes, what? And she explained, and he goes, no. In Japan, the house staff, or the staff for the hospital, is 1/3 the size of the United States. Because when a patient is admitted, the family is there to provide all the meals, take the patient on walks, you know, doing a lot of the care that nurses and nurses' aides do in this country. So their whole structure of the institution is culturally based and recognizes that the family and the patient is in that same circle. And I think it's for most cultures around the world, except the weird cultures, where individuality is primary. And you read about all the books, our novels throughout history has been the individual. And in other cultures, that's not true. So how do we then reconfigure to be open to that kind of difference? Constructs of patient-family as practitioner interactions should be based on a covenant versus a contract. In hospitals, all institutions are reflections of the culture in which it belongs. So our legal system is very much intertwined with our healthcare system. And that makes us sign posts, powers of attorney. It's actually in the title. You get your attorney or someone legal like that to sign the end-of-life decision-making. Richard Payne, whom was a dear friend, and I just heard passed away a few months ago, said that in the African American community, the relationship between the clinician and the patient should be a covenant. And that's unspoken, and there's trust. And for every community of color, I feel it's the same way. That's not how our healthcare system is structured. So the USA has basic cultural values: independence, individualism, autonomy, happiness. Okay, those all feel familiar? But for everyone else, it's interdependence, community group welfare, group consensus, and the belief that all life is suffering. I was talking with a physician who was head of the intensive care unit, and he was from Ireland. And he said, "You Americans, I just don't get it. You think you don't have to die." And I thought, wow. We also had some Irish nurses at the hospital who refused to care for these patients on their third liver transplant. They said, it's not going to work. And that's taking a liver from someone else. It would be their first, and it might take. They'd have a better chance of survival. What are the ethics in that? So when you start to hear and listen to people's perspectives, it helps us communicate more effectively. Oh, there we go. But statistically, this was a study done by Rena Pasek and her colleagues, on the deductive quantitative analysis of this mixed method study, there was no difference between groups. These were 4 or 5 different ethnic groups. Okay. But on the qualitative analyses, none of these constructs held significance or relevance for the Filipinas and Latinas. And yet we say these are valid measurement tools. So mixed methods, fortunately, as an anthropologist and a qualitative researcher, is coming, at least is rising above the horizon. So to demonstrate the salience of how we ask questions to elicit this kind of information. So culture is fundamental to human existence. And there's no such thing as human nature independent from culture. It's everything non-genetic your parents and families give to you. Throughout your life, you're going to change. I use the analogy of a suitcase. They pack it for you when you're born, and you change things out as you grow and go into different environments so that it becomes uniquely yours, but it's still fundamentally that of your home group. The 3 universals of well-being, and I use the term well-being versus health. I was at a dinner once with my husband, and there was a Native American healer. There was a Vietnamese he was an MD, but also a traditional Vietnamese practitioner. And my husband was Western-trained physician. And they were talking about healthcare. And I was listening, and I'm going, they don't quite seem to be in sync. And so I said, wait, can I get some clarification here? Tell me what health is to you. And there were 3 very different definitions, or at least my husband's, being the Western model, was very different than the other two that included spirituality as an essential part of health. That's not well addressed in our healthcare system. We may have the chaplaincy, but that's not fundamental to how our clinicians are trained to even listen for that. So in looking at cultures around the world, well-being is something that can be translated in a more understandable fashion, and you elicit how they define that. But it's the social resources and structures that provide every individual survival and security, integrity and meaning, and belonging as an integral part of a social network. So those seem to be cross-culturally valid, and if we use that framework to ask questions of our patients, they may be able, and community folks that we're working with, they may be more able to articulate how it is in their communities. So you have to demonstrate first your trustworthiness. You have to express the ability and demonstrate the ability to respect their individuality and truly go where he lives, which is a quote from a paper Dr. Blackhall and I did many years ago. And what was kind of discouraging for me, it was great, but it was also discouraging because in, 2017, there were 2 textbooks on cross-cultural end-of-life care. Both of them used our article. And I thought, in that many years, if there's nothing else out there, that's really bad. I'm glad they used it, but there has to be more attention paid to this and more work done in studying how it affects each of the questions we're interested in. Learn what and how they want the information they seek. Who should they get it from? One of the patients I worked with, an African-American woman with breast cancer, she said, I'm doing everything I can, but ultimately it's in God's hands. She said, but I'm very careful who I say that to, because most of the time if I say that, they think you're stupid, you're uneducated. She said, but I'm doing everything I can to get all the medical care I need, but I know ultimately that it is in God's hands, because maybe they're not going to work as well as they might in somebody else, and my body's different. So she understood the impact of how she talked and to whom she talked. And developing this covenant. How do you get someone to trust you? You can't just say, trust me. That's usually a bad omen to start out with. And it takes time. We try to find all these shortcuts and give them handouts and this and that's, but we forget the human touch. We're so into social media, but talking to each other. I had a student, there were 5 roommates. They were all in the apartment together because they were all upset that a couple of them weren't carrying their load. They were texting each other because they lost the art of talking to each other and connecting. That was too threatening, so they were texting, all sitting in the same apartment, but texting. So we've gotten to that point in our, both clinicians all know with the medical records, right? You're talking to the patient, but you're also just typing things in, and you need answers to the questions that are on your forms, but not connecting, taking the time it takes to connect with the patient. So in this mixed method study, as I told you, none of them worked, but these were the theories that were used, and of all of them, none of them worked in the Latino and Filipino populations. So what are we using then? We lack a scientifically grounded concept of culture. It's usually operationalized as what is your ethnicity or what language do you speak? That's not culture. It's part of it, but there's more to it than that. The integration of communities of interest in the partnership, and that requires, how many of you at your institutions have community advisory boards? great. But I'm hoping all of you will soon. To identify differences that make a difference to them in how they interact with your institutions. And we need measures that accurately operationalize the aspects of culture that most affect the issues of concern. And studies that test the hypothesis of cultural, and that's individual, I'll go into this in more detail, social, structural, and ecologic impacts on health literacy and health outcomes. So culture is a way of life and thought that we construct, negotiate, and importantly, institutionalize, and finally end up calling reality. So each of us from our various cultures have a slightly different view of reality. But despite its central role, no other variable used in health research is so poorly defined and untested as culture. So a group of us, I'd say, what do you do if you're a researcher and you are stuck? We wrote a grant and got it funded to develop this cultural framework of health, which is online at OBSSR. And there are hundreds of definitions, but none of them are usually used. It'll be language or ethnicity as your culture. So before you embark on any intervention with a population different than the dominant white culture, you have to answer these following 6 questions first. Is the rationale for the inclusion of culture clearly articulated in the problem statement? Has a definition of culture been articulated for the study? How are we going to compare studies who address culture if we don't know how they're defining it to begin with? Are select theoretical and cultural constructs known? Is there a correspondence between salient theoretical and cultural constructs? And is there a conceptual framework that specifies how salient constructs affect the health issue of focus? Have independent, moderating, and mediating variables been identified or effects? And are there cross-culturally equivalent existing measures? And I would venture that probably less than 90% would say yes to those 6. And we have a long way to go in how we change those statistics. We're a highly individualistic society in the left one. If any of you write Chinese or Japanese characters, this is the character for person, individual. Versus the I of individualism. But when children in Asia, Japan, and China are taught to write that character for person, they put 2 heads on it. So integral to the concept of individual person is interdependence. That's just a given. That's the mom and dad in the same circle as the individual. They're not separable. Punishment for an Asian kid, and this happened to me, so I can attest to it, but I'm a 3rd generation American. When I disciplined my kids, I actually physically put them outside the front door and said, you cannot come in until you can follow, I was ranting and raving at that point. My husband, in the same situation, said, go to your room and you can't come out until I tell you to. Okay? Anybody identify with one or the other? To go to the inner sanctum goes against individualism, autonomy, those values. And mine was not being able to come into the house was the punishment, the shame. And they're very different. I said, I'll let my kids handle it when they're adults. They can figure it out. But realizing how it permeates who I am. In the study that I did in response to cancer was very different for the Japanese and the Western European Americans, and these were Japanese Americans. What is the cause? It's from outside. It's something that's happened to you. You don't know. For the Japanese, almost every one of them told me it was something they did. They brought it on. They worked in the camps using sprays, spray paints, and it was probably inhaling those chemicals that they got this cancer. So they can identify what they did to cause it versus it just happens. I'm the victim. So resignation to something that you have no control over versus this Yamato Damashi for Japanese, which is you just do it. You get through it. And the fight against, do not go gently into that good night versus you just endure it. And so the two metaphors that I used was the oak tree and bamboo. Because bamboo bends, but if you've ever tried to get it out of your yard, it comes back. So how people cope with it, what's normal, productive, healthy coping is going to differ by each population group. We don't look at differences when we think of white patients. Think of the categories that we use. Each of those is going to be very different. So I think everyone has you'll get copies of the slides so you can go through the definitions, but do know that each of these is different. You can't use race, ethnicity, or you do, I've seen it, but you shouldn't. And how can we be more precise in how we talk about these differences? This is the United States now. This was in New York about 15 years ago. And this is in LA. The blending of cultures makes it difficult for people to articulate because it's kind of both and all the above. How many of you have eaten the same food from the same ethnic group for the last 7 days? No, it doesn't happen anymore. We can't, the food frequency scales are useless unless you use all the modules. So the two functions of culture is to provide its members the meaning of and for life. Why should I keep going? It's integrative and it's functional. It gives you meaning and it tells you how to behave to be that good person. And I have, 60 seconds? Okay. Do you tell the patient the truth? And the Korean patients, it was funny. First they said, no, you don't tell the patient. But this was back in 1995. But a more recent study shows that it still persists depending on which ethnic group and where it's done in the world. So, but we require physicians, right, to give the diagnosis. And in many cultures, that's not ethical. So how do you tell them without telling them? And the Japanese, being raised in that, they're very good at that. You get the message. So culture is a tool that is used for survival and meaning for life, and it's a shared framework that is socially, morally, and legally integrated into a person's sense of self. And if we don't address them, then we're missing our ability to communicate effectively with those patients, their family, and definitely their community. So all I want to finish with is when we talk about family should be involved in it, who's their family? Do you ask? Sometimes they don't want their blood family, but there's another group that they consider their family. And how often do you take the time to ask that? The circumstances that Elmer noted. What do you want to be if you grow up? So if we're working with patients and families in which survival is questionable, how good are smoking cessation programs? Father Boyle in LA asked one of his kids, who was 12 at the time, 15. How long do you think you'll live? He said, I'm going to live a long life. I'm going to make it to 19. How effective is a non-smoking? You're going to develop lung cancer when you're 40. It's not in his reality. So those are the kinds of issues we need to address when we're thinking about different population groups. We need to treat everyone equally, but that means uniquely, as an individual. And I will end with that. So our task is to be relevant, respectful, and culturally responsive to the individual and their loved ones. So, thank you.
Thank you.